A very good afternoon to all. So, after a very interesting case from dermatology and hematology together, we present to you an interesting case. So, we will say that these are the Gen Z diseases. We didn't hear when we were residents and we were consultants. So, these are the birth of last 5 years due to over the counter use of medical abortion pills and rising cesarean section rates. We are now seeing these new generation, we call it Gen Z disease. So my team will bring to you about this new Gen Z disorder and know how to manage them.
Good evening, respected faculty and my dear colleagues. Myself, Dr. Shaini from Department of Gynecology. Today's CCR topic is on unmasking vascular RPOC from misdiagnosis to preventable morbidity. Nearly 1 in 11 pregnancies in India are unintended, according to National Family Health Survey 5. Most of them unfortunately land up in unsafe abortions, which contribute to maternal morbidity. So these patients have immediate complications such as incomplete abortion, massive hemorrhage, and even uterine perforation following dilatation and curettage. However, late complications were equally significant, such as retained products of conception, vascular and adherent RPOCs, infection, septic abortion, endometritis, anemia, intrauterine adhesions and following secondary infertility, and chronic pelvic pain. There is a rising burden of post-medical abortion complications. What has changed? Firstly, wider access to over-the-counter MTP pills without medical supervision, repeated blind dilatation and curettage, and there is also rising cesarean section trends, which leads to abnormal implantation of embryo, which leads to adherent and vascular RPOC. Now today we are going to present two similar case series of medical abortions complications. Case 1, 24-year-old, gravida 3, para 2, live 2, previous to cesarean sections. At 6 weeks period of gestation, she had self-intake of MTP pill in view of unintended pregnancies. She underwent 2 dilatation and curettage twice outside and 3 PRBC transfusions. She had main complaint of bleeding per vaginum, soaking 1 pad per day since 3 months. She has been referred to AIIMS in view of ultrasound report suggestive of very arteriovenous malformations. And the second case is 28-year-old, gravida 3, para 2, live 2, abortion 1, previous 1 cesarean section. At 10 weeks of period of gestation with missed abortion, she underwent dilatation and curettage once in view of failed medical management and received 1 PRBC transfusion. She had main complaints of bleeding PV for 1 month, soaking 2 pads per day, and she has been referred to AIIMS with ultrasound report suggestive of possibilities of square ectopic, arteriovenous malformation, and query vascular RPOC. And on examination, the first case per abdomen, there is a previous cesarean scar present. PS, os was closed, minimal bleeding was present, cervix and vagina were healthy. And on per vaginum, that is uterus is 6 weeks, anteverted, bilateral fornix is free and non-tender. She has moderate anemia of hemoglobin of 8.8 gram per DL after receiving 3 pin PRBC transfusions also, and she has beta HCG value of 421 milli international units per ml. In the second case, parabdomen and per speculum examinations were similar, and PV examination uterus was 6 weeks, retroverted, mobile, bilateral fornices are free and non-tender. And she also has moderate anemia, 8.6 gram per deciliter. And there is a doubt of scar ectopic. So we did a beta HCG. Initial value is 358 milli international units per ml. And after that, we have repeated also 338 milli international units per ml after 48 hours. There is a plateauing. So I would like to invite Dr. Monica for explaining key imaging findings from radiology department.
So here we are seeing the ultrasound images. So in case 1, So this is the heterogeneous area which was seen at the scar site. So this is the heterogeneous hypoechoic lesion, mass-like lesion, which was seen at the scar site. And on the Doppler, we could see that there is intense vascularity which is seen within the lesion and also in the periphery of the lesion. And as we could see here, the myometrium is also very stressed out. So the MR findings, so this MR was done outside, and on the T1 images, we could see a hypointense lesion, while on the T2 weighted images, we could see a heterogeneous mass-like lesion. On the sagittal T2 weighted images, again, there is a heterogeneous lesion here. So we performed DSA for this case. And when we took run from the left side and then selectively the horizontal branch of the uterine artery, we could see a blush here. The vascular blush is seen. Selectively introducing the microcatheter, this was the blush which was seen. So here we have inserted the glue cast. And in the post-embolization run, we could see that there is no visible blush which was seen previously. Similarly, from the right uterine artery, selectively we embolize, and in the post-run, we could see there is no blush. So this was the previous from the left side, the glue that we inserted, and on the right side, this is the cast. So here in the run, we could see that there is no blush. So the role of intervention in radiology is crucial here because there is diagnostic role as well as the therapeutic role. So in the diagnostic role, it helps to confirm the vascular nature of the lesion. And it also helps to differentiate the vascular RPOC from secondary AVM, because in AVM cases, we will be seeing early venous return as well. Obviously, there is therapeutic role, as we had seen in our case, because then UAE here provide the targeted occlusion of the abnormal vascular channels. And there are advantages because this is a uterus preserving and fertility sparing treatment, and it avoids the major surgery and also the risk of hemorrhage before the patient could be taken for DNC. So this is a summary of the case that we have described. We've already seen a heterogeneous hypoechoic lesion at the scar site, in which it showed multiple, moderate peripheral and internal vascularity inside the lesion. MRI also we had seen. So the DSA. So this is the second case here. In this case, we see again a heterogeneous, predominantly hypoechoic lesion at the scar site. And as we could see, in this case, there is no significant vascularity which is seen inside the lesion, as we did in the previous case. And also there are only mild specks of color which are seen here. Sorry. So in the MRI again, here is the T1, Here is the T2 weighted image, and it shows a heterogeneous lesion. Again in the T1 hypointense lesion, and here in the post-contrast images, we could see that there is no post-contrast enhancement which is seen. So again, summarizing the findings, so the USG showed the same finding, heterogeneously hypoechoic lesion. This was a avascular RPOC, so the patient did not undergo DSA in this case. Yeah, thank you. These were the findings.
Moving on to the first case was referred in view of vascular RPOC, but after examination history and imaging, the final diagnosis made was query scar site adherent RPOC with marked vascularity and query scar ectopic, as there is thinning of myometrium. And the second case was referred in view of scar ectopic, but the final diagnosis made after imaging was query adherent mildly vascular RPOC or query scar ectopic. In the first case, the procedure was done was bilateral uterine artery embolization to decrease the vascularity. Then we proceeded with diagnostic hysteroscopy followed by laparoscopy. Then the diagnosis was confirmed as scar ectopic. Laparoscopic product of conception removal was done, followed by scar site defect repair, and bilateral tubal ligation was done. In the second case, same diagnostic hysteroscopy followed by laparoscopy was done, and the diagnosis is confirmed as adherent vascular RPOC, and then we proceeded with hysteroscopic RPOC removal with laparoscopic bilateral tubal ligation. And moving on to the procedure. Here, after the case 1, after bilateral uterine artery embolization, we proceeded with hysteroscopy, in which we can see large, fleshy ectopic mass in the lower uterine segment. And as we proceeded inside in the uterine cavity, we can visualize bilateral ostia, which were normal, and upper uterine cavity is absolutely normal. Then the ectopic mass was present in the lower uterine segment. And after that, we proceeded with laparoscopy, in which we can see omentum is densely adhered with the previous cesarean scar, and we can see the ectopic exophytic tissue in the lower uterine segment. And now we proceeded with uterovesical fold dissection from the lower uterine segment for proper exposure of the ectopic tissue. And then vasopressin installation is done into the uterine uterus to decrease the vascularity. And then we can see the blanching there as there is decreased blood supply. And then with the help of harmonic scalpel, we have incised over the scar ectopic tissue, and the product of conception was removed into a glove bag. Here we can see the vaginal uterine dilator, and then scar defect repair is done by freshening the edges and repairing with barbed suture. Then bilateral tubal ligation was done. And in the second case, we did a diagnostic hysteroscopy, and then we are proceeding in the uterine cavity. The fundus is normal here, and then bilateral ostia were also normal. And then there is a mild vascularity because as it is a pregnant uterus. And moving on to the lower uterine segment, we can see the same fleshy product of conception in the lower uterine segment, similar to the first case. But here in the laparoscopy, in the lower uterine segment, there is no bulge here, and the scar site was absolutely normal. And then here we proceeded with hysteroscopy RPOC removal with resectoscope. And as it is adherent, we removed with the help of his resectoscope. And after that, post-procedure hysteroscopy was done. The cavity was empty. This is the upper cavity, and lower uterine cavity is also empty. And after that, we proceeded with bilateral tubal ligation. And case 1, the histopath report, the scar site ectopic was as the diagnosis. There is chorionic villi with scar tissue was present. And in the second case, we could see decidualized stroma, and retained product of conception is given as the confirmed diagnosis. And in both the cases, the ultrasound porous procedure ultrasound cavity was uterine cavity was empty, and there are no complaints. Menstrual cycles were regular for both women. Now I would like to invite Dr. Priyanka to continue with discussion.
Thank you, Dr. Shaini. Good afternoon. Now, proceeding with the discussion, any women at the reproductive age group presenting with persistent bleeding PV after a first and second trimester missed abortion, whether it be induced or medically terminated, we should always pause, think, and evaluate before jumping onto a blind curettage, because the uterus might want to narrate a different story. So let's remember, not all post-abortion bleeding is incomplete abortion. Persistence of placental and or fetal tissue in the uterus following delivery, termination of pregnancy, or a miscarriage leads to RPOC, and it can be avascular RPOC or vascular RPOC with a 1% incidence after term, 6% after preterm, and a strikingly doubled after first and second trimester abortion. Why? Because of strong trophoblastic endometrial attachment, poor myometrial contractility, absence of a well-formed cleavage plane, fragmentation during abortion leading to piecemeal expulsion and retention. Early pregnancy tissue is also highly vascular and fragile and superadded iatrogenic and technique-related factors. The most common risk factor here is the repeated dilatation in curettage and the rising LSCS trend leading to abnormal implantation. Now, after clinical history and an evaluation, we proceed with the beta HCG and an ultrasound assessment with color Doppler to identify the pathology and determine the therapeutic approach, which brings us to a few differentials. If it is a low beta HCG, echogenic mass without vascularity, it leads to avascular RPOC. With a vascularity leads to vascular RPOC. With fever and pain, intracavitary fluid and hyperemia leads to endometritis. With the turbulent vessels, very high Doppler velocity leads to AVM, and a plateauing beta HCG rising or very high leads to gestational trophoblastic disease. Now let's proceed with today's focus of discussion. Vascular RPOC comprises 18%. Vascularization of the persistent trophoblastic tissue can lead to catastrophic bleeding if blindly curated. Why? Because the defective Nitabukes layer, failed placental cleavage, leads to adherence of the RPOC leading to vascularization. If we blindly cure it, we are disrupting a vascular placental bed and not removing the tissue per se. The red flag signs are persistent bleeding after MTP, history of multiple DNC, previous history of uterine surgery, and a positive beta HCG. So on ultrasound, if the ET is more than 15 millimeter and intrauterine echogenic mass with blood flow, it leads us to the diagnosis of vascular RPOC. So the next step is to predict the hemorrhagic complications, and keeping in mind the future fertility desire, we proceed according to the Gutenberg classification. So it has type 0, 1, 2, and 3. Type 0 and 1 can be managed expectantly, medically, or by DNC because the vascularity is quite low or absent. But in type 3 and type 2, it's true vascular RPOC. We need to think about the future fertility, parity, and anticipate hemorrhagic complications. So we proceed with plus minus uterine artery embolization and definitely followed by hysteroscopic resection. So the preventable cascade here is the most triggering factor is the abortion, postpartum state, and the retained placental tissues. Second is the missed early recognition and early referral. So we often ignore it as normal post-abortion bleeding, no early ultrasound, and lack of suspicion. The preventable point here is beta HCG and a TVS with Doppler. Third is the inadequate imaging and misinterpretation. We often misinterpret as blood clot, incomplete abortion, and GTN. The preventable step here is the assessing the vascularity. The fifth point is the curettage without any ultrasound guidance and no preparation for hemorrhage. So here the preventable point is always go with an ultrasound guided evacuation. So all these factors together leads to increased maternal mortality and morbidity, leading to fertility compromise, psychological trauma, prolonged hospital stay, multiple blood transfusion, and ICU stay. So the most critical risk factor here comes as misdiagnosis and blind curettage leading to hemorrhage and morbidity and mortality. So the management of other differentials are according to the guidelines. In endometritis, we do go with the empirical broad spectrum IV antibiotics. For AVM, we proceed with UAE, and for GTD, we proceed with NTCN guidelines. So on reviewing the literature, there was quite a paucity of literature, and we have seen that a narrative review of 20 articles where vascular RPOC is being managed via Gutenberg classification, conservative, medical, UAE, followed by hysteroscopy. A recent retrospective study in 2020 of 31 patients, vascular RPOC was managed according to, again, Gutenberg classification. Primarily, UAE was done for all the patients. Then one case report and a case series of 2 patients. A vascular RPOC type 3 and 1 managed again by UAE and hysteroscopic resection. To the contrary, It has been seen that UAE is used with wide caution in patients one desiring fertility, but on the contrary, with the evidence available and this recent study, it is seen that UAE is quite a fertility preserving modality. Here, 42 patients were retrospectively studied and is divided into two arms. One underwent UAE with hysteroscopic excision and another only with hysteroscopic excision. So it has been seen that the pregnancy outcome and the time of conception was similar in both the arms. So we can see that the available evidence suggests that selective UAE does not significantly impair the future fertility with comparable conception rates and time to pregnancy when compared with women treated without embolization. I request Dr. Neha ma'am to proceed with our unit experience.
Good afternoon, all. As ma'am said, that this is the condition we are seeing the rising incidence. So we did a retrospective study in our own unit over a period of 1 year, and we found almost 18 patients with the vascular RPOCs. All these patients, their mean age is 29.7 years. All were post-abortion cases. 10 patients were multiparous and remaining 8 patients were nulliparous. They all presented with continuous spotting and the bleeding PV, and they are all diagnosed with transvaginal sonography with a color Doppler. So we have divided these patients into Gutenberg classification. The one patient fall under type 1 and she was managed with simple DNC because she is associated with very low vascular RPOC. Remaining 16 patients, they fall under type 2 Gutenberg classification. 8 were nulliparous patients. They underwent only hysteroscopic RPOC removal. And 8 were multiparous patients who underwent prior uterine artery embolization followed by a hysteroscopic RPOC removal. The one patient fall under type 3 and she was again managed with a UA with a hysteroscopic RPOC removal. So the most common complication, the most common pre-procedural complications was anemia. One patient required repeated UA because of the continuous spotting and bleeding PV. 5 patients required blood transfusion and 3 needed post-procedural hormone suppression because of the persistent bleeding. So coming to an end and the take-home message, the management of these hypervascular RPOCs, like risk with a simple DNC in case of hypervascular RPOC may lead to life-threatening hemorrhages and endanger the life of the patient. And there lies the importance of evaluation of vascularity in all cases of RPOC prior to DNC in order to avoid the dreaded complication of massive hemorrhage. Intervention radiology with minimally invasive approach gives promising results in management of these hypervascular RPOC. It is safe, more precise, more effective, minimize trauma, and it optimizes fertility outcomes. So prior evaluation and minimally invasive approach, it improves safety and fertility outcomes. I like to acknowledge all the faculty members and the residents of Unit 2 of Department of Obs and Gynae, the Department of Radiodiagnosis and Intervention Radiology, Department of Anesthesia and Blood Bank team. Thank you. I like to invite Dr. Shiva for the expert comments.
So that was a good topic to highlight the importance of our IA work. So I don't know whether we are overdoing these procedures. I don't see we go to a lot of IR workshops or CMEs, we don't see this kind of a work. Are we overdoing this procedure in our center? Because this facility is not available across the country. Because this RPOC entity is not only pertinent to Delhi or whatever in referral center, people might be getting these cases in across the country. This facility like UAE is not available, or it is available, but the gynae people or the specialty people, they are not asking for this UAE procedure.
I think that's true, sir. Maybe we are diagnosing.
Yeah.
Yes.
We are happy to provide that service, but only one question always comes is that, are we overdoing this procedure?
So we really don't have the data. There is no published data from India. As when we reviewed the literature, the data, there's a great paucity of data. There were only 2 large series. And when we looked at the data at our own center, we found 18 patients in only single unit. If we collect the data across the department, I'm sure it is going to cross 100 of patients.
We are getting from all the
these patients, you see that many of these patients have received multiple blood transfusion. One patient received 5 units of blood outside and she was still bleeding. For past 3 months, she was bleeding and she was being given different treatment. She would have died actually when she reached us. Her hemoglobin was 6 in spite of receiving 3 units of blood. And she had such a big vascular mass, the first diagnosis, the one which was referred to us for AVM.
That's why we don't refuse.
Yeah.
Okay.
So I say that when we see these vascular masses, definitely we are at advantage because of you. So we feel very confident, okay, let's kill it. First kill the blood supply and then we tackle the mass. So we are able to confidently manage these patients and save fertility sparing treatment. Otherwise, many of these women, I don't know, they may be rendered to hysterectomy. We have no data. We don't know.
We don't know the outside what is happening.
Yes. So many of these patients may be rendered to hysterectomy because of intractable hemorrhage. But we feel good, okay, let's challenge. The main challenge is vascularity. We take help of your expertise and reduce the blood supply. And then we feel more confident, okay, we can do hysteroscopic surgery, laparoscopic surgery, whatever we want, and we come out with excellent outcome. And it is a fertility. These women are all young. You see, one was only 24-year-old. Doing hysterectomy in a 24-year-old woman is not justified. Looking at such an aggressive mass in the uterine cavity, I'm sure if she would remain outside, she would have undergone a hysterectomy for intractable bleeding because she was given all possible treatment, but bleeding was, they were pumping in blood transfusion and hormone treatment, but bleeding was not stopping. Then they said that is AV malformation. You kindly go to a center for UAE. She was referred to AIIMS for UAE only. But when we looked at her features, the radiology and everything, we said that this is not AVM. Either this is a scar site ectopic or it is a vascular RPOC. And then when we went ahead with the scopy and the diagnosis was made and she was helped and she's fine. The follow-up ultrasound, you can see the uterus is doing fine. And she's absolutely healthy, only 24 years. The second patient was 27-year-old.
Just a question is that have they conceived again after this embolization?
No, so both of them had previous cesarean sections. Okay. First patient had 2 issues. Second also, she was not desirous of future pregnancy. They were young women, but they had completed their family. But it doesn't, justify doing hysterectomy even if they don't
both
want.
the cases were ligated anyway. So, but I think there have been, sir, for your question, I think UAE, we have had pregnancies after UAE. That is one thing. But here, ma'am, I think very nicely managed cases. So the first, of course, is not an RPOC. It's most unfortunate case of scar ectopic where you have an abortion in scar ectopic pregnancy and then that's a very different thing. And sir, I think in that case, UAE is justified. I mean, that is something because it's a scar ectopic. But when we talk about RPOCs and what sir is saying is, are we overdiagnosis? I think that's something that we really need to reflect. Also, sir, I would like to really know, because now we have definitions which are called as enhanced myometrial vascularities, right? See, suddenly an RPOC becoming vascular, that's also, and it's also defined that if the velocity within the RPOC is less than 20, you don't need to do anything, just give her medications and you follow it.
No, Aparna, these two are different entities.
AVM,
myometrial vascularity is a very different entity. It doesn't have a mass
so
inside the
basically,
uterus.
that's also true. You can have an RPOC, but there is an increased mass because AVM is typically referred for something which is congenital. Whenever it's an acquired thing, now it's called EMV, but associated with an RPOC. Now, if we had given a medical management, now the question is, if you have an RPOC, you have to remove it. That's our only question here, and that's why. But in most of the cases, they do respond to medical management also. But yes, like we said, if the vascularity within the mass that we are seeing is beyond a certain limit, then we should ask for the radiology intervention and not for very low level masses. We tend to kind of overdo this in that sense also, that even the ones which are not very high flow, they are also referred to IR just because we have it. Yeah. So I think that is what is making a difference. So I think that kind of a cutoff, and that's why we also send it for, like, once we see that, okay, it doesn't look very much, but we also send it for confirmation that if it doesn't look too much, don't do it. I think that is where we also need to step back a bit. And if we feel that the vascularity is less, we don't do it. And we take that thing of doing a VA without, just because we play safe. I think that is our problem also. That's what I feel.
Any other questions or comments? Most welcome. Now, because she's ligated, both of them are ligated, the recurrence. Otherwise, yes, very high. Because there is a defect and the implantation can anyway re-happen in the same defect.
Scar uterine in any case is a high risk for the adherent RPOCs or scars. Yes.
Ultrasound, yes. Yes. No, pelvic Doppler, like we do for all intrauterine pathologies, we do transvaginal sonography with Doppler. So that is the,
Most of the time it is complemented with transabdominal followed by
yeah.
But do we need MRI?
They had it from outside. Both of them.
But I think in scar ectopic, we can go for MRIs just to confirm and to make the diagnosis.
Okay, thank you very much.